and everyone present here. I, on behalf of Veiva Scientific, welcome all of you to the Consteel IVUS NIRS webinar. This platform brings together national and international experts to share insights and experiences on advancements in cardiovascular therapies and interventions. We are honored to have a distinguished panel of experts of interventional cardiology with us here today. The therapy experts for the evening are Dr. D.S. Chadda sir and Dr. Deepak Davidson sir, the names that require no introduction. I would kindly request our therapy experts to please take over and lead the session. Deepak sir, over to you.
Can you see my slides?
Yes, sir, we can.
Okay. Good evening to all of you. At the outset, let me thank the organizers, especially the team Veiva, for having given me this opportunity. I was supposed to speak after Dr. Chadda, primarily on a new concept. But then I think Dr. Chadda, he's actually stuck in the traffic. I can see most of us in the vehicles. Even Rahul is traveling, I believe. Me and Dr. Viveka at home. I shall share with you just few slides on what exactly is NIRS, what exactly is the technology, what exactly do we identify in Makoto system, and then I'll move on to my topic. And towards the end of the session, Dr. Chadda will be sharing with you on what are the clinical applications of this particular system. Well, what exactly is NIRS? It basically identifies the composition of the plaques. That's it. Looks at the lipids inside the blood vessels. We all know that when you have a huge amount of lipid inside the blood vessel, this correlates with increased events during the follow-up of our patients. So this particular technology, with the help of this particular technology, you can identify a vulnerable plaque, and you can also identify a vulnerable patient so that you can be very aggressive in treating these patients with statins or something more than that. And this is what you see on this particular chemogram. When you see these sort of yellow patches on the chemogram, it identifies that this particular area in the blood vessel has got significant amount of lipids over there. Now, coming to the technology as such, that's basically the Makoto system. In this Makoto system, you have a catheter. At the end of the catheter, you have two transducers. One is the NIRS transducer, that's a near infrared spectroscopy. And on the other side, diametrically opposite sides, you have the second transducer, that's the IVUS transducer. So with the help of IVUS transducer, you look at the structure of the blood vessel. That is like what we routinely see with the help of an IVUS. That is what you see with the IVUS transducer. And with the help of the NIRS technology, you get a composition of the blood vessel. So you get an idea regarding the structure as well as the composition. You can get an idea regarding whether it's a lipid pool, whether it's a calcified plaque. All such information could be identified with the help of IVUS. And the NIRS also helps us to quantify where exactly you have huge amount of lipids, which area is the vulnerable plaque, is the plaque vulnerable or not. Those sort of information you get with the help of IVUS NIRS technology. And this is what you see on the monitor. In the monitor, low down there, you can see the IVUS image. That's the IVUS image. That's the longitudinal image of the IVUS. And on the upper half, you get an idea regarding the lipid pool inside the blood vessel. So you get an idea side by side. You get an idea whether this is a plaque over here. Does this plaque have huge amount of lipids or not? So that is how you would correlate whether the whatever plaque you're seeing, whatever vessel you are seeing, whether it's a hugely lipid-filled plaque or whether it's a fibrotic plaque. That is what you would understand with the help of this particular technology. And when you look at the B mode, in the B mode, again, similar to any IVUS system, you get an image of the IVUS, that is the cross-sectional view of the blood vessel like this. And then when you look at the periphery, you get an idea regarding the lipid pool. When you have huge amount of yellowish color like this, you would identify that it's a huge lipid pool. And when you have a red area like this, you understand that it's not a lipid pool. So this is what we would look for when you evaluate IVUS NIRS in most of our patients. So that's just the basics. Now I shall take you through my presentation as such. So this is my presentation. Okay, well, beyond the calcium, IVUS NIRS in calcified acute coronary syndrome producing lesions. Well, we all know that when you have an acute coronary syndrome, around 1/3 of these acute coronary syndromes are produced by calcific lesions. So when you look at the calcific lesions with the help of optical coherence tomography, you could see three sort of morphologies. So in the first image, you could see that this is basically a calcific sheet. You can see that there are thin areas of calcium. You can see thick areas of calcium also. So that's a superficial calcific sheet that can lead on to acute coronary syndrome. The second morphology would be an eruptive nodule. You can see that there is an eruptive nodule over here. This too can lead on to an acute coronary syndrome. And in the third image, you can see that it's a nodular protrusion into the vessel. Very rarely, the nodular protrusions also can lead on to acute coronary syndrome. So this was an elegant article, Japanese article published in 2019, which says that when you look at patients with acute coronary syndrome, when you evaluate only the calcified lesions, you could see that almost 2/3 of these acute coronary syndromes are produced by the superficial calcific sheets. Around 1/3 it's produced by the eruptive nodules, and very rarely acute coronary syndrome is produced by the calcium protrusion. Now, managing these lesions, all these lesions, it's going to be different. The approach is going to be different when you see these sort of three different lesions. Now, when you see a thin superficial sheet of calcification, it's very easy for us to fracture. If it's very thick, it's difficult to fracture. But if it's a thin one, it's easy for us to fracture with any balloons. Now, when you have an eruptive nodule, again, it's easy to deform these eruptive nodules, and you can easily deploy a stent over there. But then when it comes to a nodular protrusion, it's not easy for us to deform it with the help of balloons. Whether it may be an IVL or any sort of balloons, it may not be easy for us to deform. So that ultimately at the end of the day, you might not have a good stent expansion when you have a nodular protrusion into the lumen. Now, coming back to an eruptive nodule, this is how an eruptive nodule would look like. You have a disrupted cap for these eruptive nodules, and you have thrombin on the top of this, and you also have a lot of lipids and fractured calcium inside the eruptive nodules. So when you have an eruptive nodules, the word itself, it says that it makes us understand that it's a ACS producing lesion, and it's not going to be a very tough lesion like a nodular protrusion. You can put in a balloon, you can put in a high pressure balloon, and you can compress it, you can deform it. So when you see an eruptive nodule, you're not very unhappy. You can have a proper stent expansion, even though we know that when you deploy a stent in an eruptive nodule, you are likely to have more of MACE in future. So it comes back with vengeance. You can have further problems when you deploy a stent in the eruptive nodule. Even though if you achieve a good, perfect result, these eruptive nodules can grow through the stent struts, and ultimately further leads on to ACS in future. Now coming to the nodular protrusion. When you have a nodular protrusion, you see a nodular protrusion on OCT, or you see a nodular protrusion on IVUS. Now, how do we understand whether you are able to deform it, whether you are able to compress it, whether you are able to deploy a stent with ease in that particular nodule? The OCT may not give us much of information regarding that. IVUS also wouldn't give much of information regarding that. That is where we need to look at this particular concept. It is said that even when you have a nodular protrusion, 50% of nodular protrusions can be deformed. Now, why is it so? Basically, you could have two types of nodular protrusion. If you look at the first image, you can see that this particular nodular protrusion, it's actually sitting on a lipid pool. But when you look at the second image, you can see that this particular nodular protrusion, it's actually sitting on a calcium. So when you have a nodular protrusion, which is actually sitting on a lipid pool, you can easily compress it. And when you have a nodular protrusion that is sitting on a hard solid rock of calcium, it may not be deformable. So the first instance, when you have a lipid base and a calcium nodule, you can easily deform it with the help of non-compliant balloon, cutting balloon, or scoring balloon, and you can deploy a stent over there. But then when you have a calcific base, it is not going to be easily deformable. You might need an IVL or so for deforming it, and you need to fracture it with the help of IVL balloon. So understanding whether you are encountering a calcium nodule sitting on a lipid pole or a rocky calcium area, you need to have a technology. Can this be identified with the help of IVUS or OCT? Certainly not. OCT cannot look beyond the calcium nodule and see whether it's sitting on a lipid pool. IVUS also cannot look beyond the calcific nodule and see whether it's sitting on a lipid pool. Now we have the NIRS system, which can certainly look through. It can peep through the calcium nodule and see what is happening behind the calcium nodule and identify if there is significant amount of lipids over there. If there is significant amount of lipids over there, then you know that you do not need any ultra high pressure balloons or sophisticated balloons like IVL. You can just go ahead with a non-compliant cutting or a scoring balloon, and then you can deform it and deploy a stent over there. So this is again the same image that I showed you earlier. With the help of NIRS technology, you look at the composition of the vessel wall, and this is what is seen on the chemogram. That's what is seen on the display. Here you see the IVUS image. You can see that there is a calcific area over here inside the IVUS. And when you look at this particular image, the chemogram, you understand that there is significant amount of lipids over there. So that you understand that beyond the calcium plate or beyond the calcium nodule, it's likely that you're going to encounter a lipid pool, so that you don't have to be very aggressive in managing this calcified plate. So that is a sort of information that we would achieve. Now, how do we identify if the calcium plate is sitting on the lipid pool? Now, this is how you would identify that. This is basically the IVUS run. You can see on the IVUS image that this is a blood vessel. That's a longitudinal view. And you can see that this particular area, there is a tight lesion. Here again, there is a tight lesion. You can see that it's a calcified area. That whitish things makes us understand that it's a calcified area. Now you look at the chemogram. Now, when you look at the chemogram, this particular area, you don't see anything yellow over here. And this particular area, you see that there is a lot of yellowish color over there, which makes us understand that that particular area has a lot of lipids underneath, which makes us again understand that we can easily deform that with the regular non-compliant balloons or so, not going at very high pressures. Again, this is the cross-sectional view of this particular image. You can see here that it's almost 360-degree arc of calcium. You can see that there is a thin area wherein you have a break in calcium, or you have a discontinuity in calcium. And when you look at the NIRS image, if you look at the periphery, you can see that it's more of yellowish color, which makes us understand that this particular calcific plate is actually sitting on a lipid pool, so that it might be easy for us to break it open. Now what does this mean? This means that when you see these sort of yellowish things at the calcified area, it makes us understand that you are likely to, you'll find it easy to break this calcium, and you can easily deploy a stent. This is another example. You can see in this particular patient that this is the IVUS run. In the IVUS run, you can see that there is a long area, a diffuse calcified lesion over here, which is again a catheter hugging stenosis over here. Now, when we look at the lipid pool, you can see that there is some amount of lipid over there, but then it is not as dense as what you saw in the other image. We can also quantify this lipid images. You can get an idea regarding an LCBI, which Dr. Chadha would be talking to us. You get an idea, you can quantify the amount of lipids. When you have huge amount of lipids, if the score is more than 400, you know that it's going to be a huge pool, it's going to be a vulnerable plate, there is huge amount of lipids over there. So that also can be quantified with the help of this particular NIRS system. Again, when we look at the horizontal image in this particular patient, you can see that it's almost a 360-degree arc of calcium. And when you look at the outer border, you can see that it's more of reddish in nature. When you see these sort of reddish things, you know that there is no significant lipids behind the calcium, which makes us understand that we are not encountering a simple lesion. It's a difficult nut to crack. You need aggressive way of managing. You need to find out some aggressive way of managing this particular calcified area. So that is the sort of information that you would get from the IVUS NIRS system. Again, coming to this particular IVUS system, this IVUS system is as good as any other IVUS system that's available in the market. It's a very sturdy catheter. It can be pushed through any tight lesion. The image quality is perfect. It's as good as any other competitive brand. And with the help of IVUS, you get a picture regarding what you are encountering in whatever vessels you're looking at. This was an elderly gentleman who presented to us with the effort angina and rest angina. His troponin was positive. You can see that he's got a very critical stenosis in the proximal LAD. You can also see that it's a calcified lesion. Now, we started this particular patient with the rotablation. You can see the amount of calcification. It was initially difficult for us to get across the lesion. However, in the second image, you can see that we were able to get across that image at higher RPMs, around 220,000 RPM. We were able to get across the lesion. Now, following the burring, you can see that the vessel is diffusely undergone spasm. You can see that there is significant amount of spasm. Now we go with the IVUS NIRS catheter across the lesion. You can see how easily we were able to get the IVUS NIRS catheter across that calcified lesion beyond that particular area. Now, when we looked at this particular area, you can see that there is significant amount of calcification over there. As I have showed you earlier, the lipid score was quite high in this particular patient, so which makes us understand that even though there is 360-degree arc of calcification over there is huge amount of lipids underneath, and so that we'll be able to break it open with any sort of balloon. So it's easily breakable, and we went ahead with balloon dilatation. So that's the run over there. You can see that there is 360-degree arc of calcification, and you can also see that the lipid score is extremely high. Anything above 400 makes us understand that there is a huge amount of lipids. It's almost 746 beyond that lipid pool. And then in this particular patient, we went ahead with a non-compliant balloon, dilated it and opened it up. You can see that we were able to easily break it open, and that's the flow following the balloon dilatation. Once we were done with that, we further did a IVUS NIRS evaluation. You can see that there is significant amount of fractures over there. You can see that there are multiple areas of fractures. You can see the amount of fractures at 11 o'clock, 12 o'clock position. And you can also see in the chemogram that majority of the lipids have disappeared from there. So that makes us understand that we could easily break it open with the help of a non-compliant balloon. And that's the final result with the help of a stent implantation, and that was the final result. You can see that the flow is good inside the vessel. Now, coming to my second patient, you can see that this was a very elderly lady, 83 years old, who presented with recurrent rest angina, ischemic left ventricular failure, a near total occlusion, a calcified lesion in the proximal left-handed descending artery. And we were very fortunate to get across the lesion with a fielder XT wire. None of the wires would go through that particular lesion. Now, as we tried to open it up, we were not able to negotiate any balloons through that. Even a 1 millimeter balloon couldn't go through that. Our plan was to get an 1 millimeter OTW balloon distally across the lesion and then to go ahead with rotablation. You can see here that the 1 millimeter over the wire balloon also wouldn't cross the lesion. Finally, we had to resort to laser. And with the help of laser, we were at high energy and high frequency with some contrast lacing. We were able to get the laser catheter across. Now, once the laser catheter was across, in the second image, you can see that the balloon was easily tracking in through that particular difficult lesion. That is the OTW balloon. And once we got the balloon distally inside the vessel, we exchanged it for a rotafloppy. Went ahead with rotablation, 1.25 millimeter burr, followed by 1.5 millimeter burr. And then once we are done with rotablation, we did an IVUS NIRS evaluation. So that's a NIRS catheter across the lesion. We were interrogating that particular lesion. Now you can see here that there is huge amount of calcification in this particular vessel. In the longitudinal view, huge amount of calcification. You can again see in the chemogram, there is no huge lipid pool over there. The lipid score is 258. There is no huge lipid over there, which makes us understand that it's not going to be very easy for us to crack that particular lesion. You can see that it's 360-degree arc of calcification. And you can also see that it's all reddish over here. It's not yellowish over here. So there is no huge amount of lipids over there. So it would be difficult for us to crack this lesion. We tried to crack this lesion with non-compliant balloons at 26 atmospheres. We were not able to do that. And finally, that's an IVL. With the help of IVL 40 pulses, we were able to open it up. And following that, you can see there are multiple fractures. That's a beautiful IVUS image. The IVUS quality is so good that you can see the amount of fractures over there. And following that, we were able to deploy a stent, and that's the final result that we could achieve in this particular patient following the stent implantation. So, dear friends, my idea of this particular presentation is to make most of us understand that this particular technology, it can peep through a calcified vessel and a calcified lesion and make us understand whether this calcified plate or whether this calcified nodule is sitting on a lipid base or whether it's sitting on a rocky hard area. If you understand this particular concept, it will be easy for us to choose the sort of balloon in the balloon-based strategy, whether you are going to manage this particular lesion with a very aggressive strategy or a less aggressive strategy in managing these particular patients. Thank you so much for your patient hearing.
Thank you so much, Deepak sir, for this wonderful presentation. And it was an interactive one. I'm sure our audience must have learned a lot. Now, I would like to request our speaker, Dr. P. Balaji sir from Madras Medical Mission Hospital, Chennai, to take over the screen. And welcome, sir. The stage is all yours.
Can I ask? Yeah.
Yes, sure, sir. Please go ahead.
Yes, Rahul. Rahul, I hope you are at India Valves.
No, I am because my colleagues wanted to go, so I did not attend. Anyways, fantastic as always. Just wanted, so if you find a lipid-rich background, then that means you don't need to do aggressive modification of the profile. That's what you have concluded. So that we can use a little lesser aggressive therapy, and these lipid plates are thinner. So I think that's a very fantastic point. And second is, you mentioned that after the stenting, sometimes the lipid core burden index had gone down. But suppose the lipid core burden index doesn't go down, does it carry any significance?
We do not have any data looking at this particular point, but then there is two hypotheses looking at two explanations why you could have this sort of lipid pool coming down following the balloon dilatation and stent implantation. Few people say that you can have some dysembolization when you have huge amount of lipid pool, and you can also have redistribution when you have this particular lipid concentrated at a particular area. It makes us understand that it's a vulnerable plate. When you balloon dilate it can spread apart, so then the score, it comes down. When the score is less than 60, then it wouldn't identify that particular area as having lipids. So that's the reason why following balloon dilatation or a stent implantation, usually the LCBA, it comes down. Chada sir, your take on this.
So I just joined. I think what Rahul wanted to know whether the residual LCBI score will have any bearing on the outcomes at a later date. So there's only one paper, Rahul. This is of about 200 patients where they noticed that leaving a residual score of more than 200 leads to stent failure. It basically increases the rate of stent failure by two folds. But this is just as what Deepak was mentioning, a hypothesis generating paper. So we need much more data to say that. We have absolutely no control. Whether there's no way we can control the residual LCBI score, and there is no hypothesis as of now which tells us as to why it comes down, whether it spreads there, or there are studies where they put distal filters and captured the lipid material. They've done histopathology of those filters and seen. So there's definitely some distal embolization, some spread over the vessel circumference. So no one really knows what happens and why it comes down. But in one of the papers, it has been shown to be an adverse marker for the stent failure.
Right. Thank you.
First of all, we all welcome Dr. D.S. Chadda sir also. Sir, you along with Dr. Deepak, sir, kindly take forward the session.
Yep. Okay. Wonderful. I think Deepak is doing a good job. I don't have to do anything. I'll just pass one or two comments. And nice to see Dr. Viveka Kumar.
Yeah, hi, how are you? So,
Welcome. Wonderful. Wonderful. Who's next on the? I don't have the
Sir,
Deepak. Why don't
we
you take
have
it
Dr.
forward?
P. Balaji, sir, to join
Okay.
us
All right.
for the next presentation.
Thank you, Veiva Scientific, respected chairpersons and moderators. Chada sir, I think you hope remember me. We met
Yes.
in
Yes.
I will present. Maybe we have started recently this NIRS. So I will present two interesting cases which we have done recently. I think which Dr. Rahul has asked, but I think especially in an ACS situation, it will definitely NIRS is going to, because it's going to give us an indication about the composition of the plaque. Probably we'll become wiser in choosing the plaque modifying strategy. I will show two interesting cases: 64-year male, diabetic, recent antral MI, single vessel disease, moderate LV systolic dysfunction. Essentially, it is a single vessel disease. If you could see, the lady has got a hazy lesion abutting the diagonal. RC is free of disease. So we wired, and then we did a IVUS. It's a pullback from LAD. Predominantly fibrofatty plaque. So the LCBA was 869. If you see, there is a significant LCBA across the lesion site. So we thought that rather than doing pre-dilatation, our IVUS went with ease. The minimal area was less than 3.5. So we went ahead with a direct stenting. So we took a 2.75 34 millimeter regulating stent. Pre-dilatation was done, but at suboptimal atmospheres. Probably as expected, because the lipid core burden was too much, there was a significant slow flow. We gave intracoronary SNP. The flow improved. We went ahead with the post dilatation. This is the post PCI. The stent edge is fine. It's a circular expansion. So most interesting fact is, if you see there was some distal under expansion. So if you see the longitudinal image, it is almost quite clear that you can't see any of the lipid core, as was discussed. Probably the flow improved. We gave lots of SNP. The distal under expansion was treated with a 2.75 non-compliant balloon. So at the end, the LCBA was quite less. So if you see, it is a longitudinal view, shows that what was seen before the stenting, you could see that the LCBA is totally gone. Probably we have compressed the lesion well. The expansion is good. Only thing is, the NIRS helped us identify that, this fellow could go in for a significant slow flow, which happened. And probably we pre-dilated, but, we didn't go very high atmospheres as we used to do in our routine cases. So the stent area was quite good. So this is the final result. I will show one more case and then I will. This is a 60-year-old female, diabetic, hypertensive, anterval MI, delayed presentation, mild LV systolic dysfunction. You could see significant tide disease, or she had a non-flow limiting disease. We want to do a pre-IVUS, but once the wire went in, she had a significant slow flow. She developed pain. So we thought that we would pre-dilate it and then do a IVUS to decide about our strategy. What we have known in doing a Makoto IVUS is probably we need to give a constant push from the syringe so that, it keeps clearing the IVUS. Otherwise, the image gets blurred in between. You could see some calcium, but not significant. As you could see in the outer circle, it is predominantly yellow, indicating that it is only a superficial thin calcium with a dense lipid core behind, which indicates that we can push it or get away with the non-compliant balloon. If you look at the lesion site, the LCBA is quite high. It is 824. It is after pre-dilatation with the 2 millimeter balloon. So the distant reference is 2.4, proximal 2.6, with the MLA of 2.2 after balloon dilatation. So we prepared it further with a 2.5 non-compliant balloon. I will show the NIRS. It is still there, but even though it has come down from 849 to 790, we didn't have much of a slow flow. We went ahead and stented with the 2.5 to 38 millimeter stent. The distal stent edge is good. It is a circular expansion. We have some under expansion, but we post dilated it again. The circular red circumference shows that the stent expansion is quite good. You could see that we have almost cleared. The LCBI is quite less. Proximally, there was some under expansion. We post dilated with a 2.75 non-compliant balloon, and distally with a 2.5. This is the final IVUS. So, the stent expansion is circular with a quite good apposition and expansion. So if you see the longitudinal view, the expansion across the stented area is quite good. The lipid burden index has come down significantly from 849 to 337. It is less than 400. The MSA was quite good. It is 6. This is a final image. Thank you. It's open for discussion.
Thank you, Balaji. Those were nice cases. I will straight away come to one of your comments that with the IVUS NIRS system, one has to use a small syringe and keep purging. So I'll tell you something. Whenever you're using IVUS, when we prepare the catheter, we should at least purge the catheter with, if no less than 15 or 20 ml of saline. And this, I'm talking from my personal experience, whether it's a Boston or the Makoto system. And this you have to do very slowly. If you purge with a lot of force, at the end of your moment you stop, the air gets sucked in. Because you generate a lot of, it's the same physics principle where we were taught that if you're standing on a platform where a very fast train goes by, the pressure falls and you tend to fall towards the train. So when you purge it at a very high pressure, or the better way is that dip it in a bowl of saline and then purge it. Or if you're purging it, you have to purge it very gently. So I could see in the first case when you were mentioning there was a persistent halo around the catheter, which implies that there are air bubbles, small air bubbles which are still inside. But if the catheter is purged nicely, you won't have the trouble of purging in between. Now the downside of purging while you're acquiring the image is that it kind of produces some rotational deformities, because the catheter spins while taking, so can make your measurements slightly inaccurate. So that is one of the downsides. So if you purge it well before you go in, so I don't think you'll have problems in that. But having said that, I was there for 2 days in Triple M and I quite enjoyed. The day I left early, Ajit called me and told me that we did 16 cases.
Yeah, sure.
So I think I'm very happy to note that you all are enjoying
Yeah,
no, it is a good system and very futuristic. There was a question in the chat box as to why should we be using. So when I give my talk, I'll cover and I'll give the reasons as to how it is different and why should we be relying on this new NIRS system. So Deepak, comments, and if you can take things forward. I don't have the list of speakers with me.
It's the same point that went through my mind also regarding the catheter being purged during the imaging. We never do that inside the coronary artery because there is always a small risk of air embolism also into the coronary artery while purging the catheter inside the coronary. We always, as Shraddha sir has mentioned, we always do that extremely carefully. We are extremely careful with that. And once we are done with, because we had a bad instance of doing an OCT, the image was not looking good. So somebody purged inside the coronary artery and it was full of air embolism. So after that, we never purge whatever be the catheter system, OCT or IVUS or anything. We never purge inside the coronary artery. And most of the time, the images are all really good. Unless it's a really Oxford catheter, you use it multiple times, the image quality goes away. But then otherwise, the images are all always beautiful. And again, in your image.
Now you are muted, Dr. Deepak.
So can you hear me now?
Yes, you're audible.
With the help of the IVUS system, we saw that there was significant attenuation of that lipid plaque. So even with the help of IVUS images, we were clearly seeing that it was an attenuated plaque. And around that, we saw that yellow halo, which makes us understand that it's more of lipids. So double confirmation with IVUS as well as with NIRS that it's going to be a vulnerable plaque and it's going to embolize once you dilate it.
Okay. Wonderful. Any other comments from the other experts in the panel? If not, we'll go to the next case. Is Dr. Tehseen there?
So Dr. Tehseen is not available with us due to.
So we can go with Ajinkya. Dr. Ajinkya, if he's there, he can present his case.
Yes, sir. I'm here, sir. I'll just share my PPT first, sir.
All right.
Am I audible, sir?
Yes, you're audible.
Thank you, first of all, Veiva Scientific for giving young cardiologists like me to present my case in front of stalwarts of cardiology.
Yeah.
Yeah. So this is a case. This is a case of 68-year-old male who presented with dyspnea on exertion and a typical effort angina. ECG was normal sinus rhythm, no ischemic changes. Echo was absolutely normal. CAG was done outside and it showed ostial mite plaque, LMCA. LAD had 80% proximal lesion. LCX was non-dominant with proximal 70% lesion with high OM of 70% lesion. And RCA was dominant with the mite plaque. He was advised CABG outside, but he was not willing for CABG. As we don't have the coronary angiography CD, we will show the angiogram of the angioplasty directly. So this was the caudal view, which showed that it had LMCA ostial lesion, as well as a lesion in the confluence of LAD and LCX, with high OM originating near to the confluence only. Here we can see it quickly. In the cranial view, we also can see the proximal part of the LAD has a critical lesion, and mid was normal, distal was slightly diffusely diseased artery. So we did the IVUS. IVUS showed mid lesion was normal, but it had a mid LAD had a fibrocalcific lesion. There were fibrofatty plaques here, with some spurs of calcium here. Now coming at the confluence, we could see there were few spurs of calcium. And the LMCA, the plaque was extending into the left main. And there was a critical lesion at the ostium as well. So the MLA at proximal LAD was 3.9 and MLA at LM ostium was 5.4. So this is the LM ostium with the MLCA of around 5.4. Lipid burden was around, this is 232. So that means that the lipid was not that high and it was a fairly calcified lesion there. This was LM ostium, MSA of 5.4. We did a IVUS of LCX2. Distally, it was a fair vessel. MLA here in the ostium was around 3.9. And we could see that the OM, high OM had was disease-free. Here it was slightly calcified disease. The AOM was slightly disease-free. Yeah. The LCBI score here was 460. So we decided to go for a strategy of bifurcation strategy. So we, since it was a calcified lesion, we did a pre-dilation of LAD with a cutting balloon. We used Aperta 2.75. We went at high pressures, 14 and 16. We also did a pre-dilation of LM ostium also with 3.5 NC. L6 pre-dilation also was done with 2.75 non-compliant balloon. We also used 2.5 Aperta cutting balloon here. And then we decided to go for stenting of the mid LAD segment, as the length of the disease was around 46 mm. We use a 3015 mm stent in the mid LAD, and we use the same balloon for mini crush. We placed another stent in the LCX ostium and crushed it with the same balloon. After rewiring, we went ahead with stenting of left main to LAD. After which we saw that the ostium of the left main was nailed. So the post LED IVUS run of NIRS, it showed the stent was deployed at exact locations. There were no dissection anywhere, and there was some areas need to be dilated at higher size balloons. So distal edge of the stent was fine. There was some part which needed to be dilated again. The calcium spur which we had the tightest area seems to be well opened here. This is the circumflex, the crust segment here. LMCA needed to be pot here. This was before pot. LMCA seems to be okay. With a few studs in the aorta. So we did a kissing with 3.5 and 3 NC, and we did a pot with 5 balloon, and we could see a fairly fine result. Final IVUS run showed we have achieved a good MSAs overall. So this was a distal LAD which had achieved an MSA of 8.0. The plaque burden was coming down to 126. And this is the proximal LAD, which MSA of 9.1, and the LM ostium of around 10.3, 10.5. So this was the final angiogram. Showing good TME3 flow and no dissection anywhere. So yeah, we can have a discussion on this. Thank you.
So the case is open for discussion. Comments from the experts who are there. Deepak, would you like to say something?
Yes, certainly. So can you hear me?
Yes, you are audible.
Like, Dr. Ajinkya, could you tell us what way did IVUS help you in what way did IVUS and what way did NIRS help you in modify your decisions in this particular case?
Yes, sir. So, IVUS actually helped me with I initially thought that I would go. Am I audible?
Yes, yes.
Yeah, you're audible. If you can your screen, then we can all see each
Yeah.
other.
One second, sir. I'll just stop my sharing of the screen.
You can keep speaking while you unshare your screen.
Yeah. So I went ahead with provisional strategy because initially I thought that the disease on the LCX was not that significant, as well as the LM ostium also was not significant, because as such I could not find any pressure dampening there. And as I did, I was the L6 ostium, the lipid score was around 460. So that was the point where I decided to go for bifurcation strategy rather than the provisional strategy here. Also, the left vein was very long. So that was the point when I decided that the LM ostium also has to be covered with the stent.
That's a beautiful explanation of getting a lot of information with the help of NIRS system in your case. Even that was what that went through my mind too, because when you did an IVUS evaluation of the circumflex ostium, it was nearly coming to 4 millimeters square. The minimal area was 4 millimeters square. So we do have data that when you have a luminal area of less than 4 millimeters square and a plaque burden of less than more than 50%, then you're likely to close down the circumflex. You are likely to produce an ischemia in the circumflex territory. And this was just borderline when you did the IVUS. But when you did the NIRS, with the help of NIRS, you showed us that it was not only a borderline lesion with the help of IVUS, you also made us understand that it was a lipid pool sitting over there. So you were totally justified in having a stent over there. So that you could probably reduce the MACE in future. Chadha sir would argue that probably you can keep them on inclisiran too. But to me, when we saw any borderline criteria based on IVUS and a NIRS criteria, which makes us understand that the lipid pool is quite good, I would also certainly go ahead with 2-stent strategy over there.
Yes, sir.
So any other comment before I give my comments? And I think I'm the last batsman standing here. So Ajinkya, a case well done. But few things I would like to point out. You are in the budding stage of your career, and you're doing IVUS, and IVUS, enjoys certain virtues over OCT. Virtue number one is that you prepare the catheter, de-air it, and forget about it. Then it'll do everything for you. You don't have to engage your guide. You don't have to make it coaxial. You don't have to do anything at all.
Yes, sir.
So what you have to do, ensure is that when you put IVUS into your coronaries, please disengage the guide. I would have been very happy in the pre-run had you shown me the aorta.
Yes.
Correct? So if you have slightest of suspicion of osteal disease, please disengage the guide and let the camera float out of the ostia into the aorta. That is the best way of assessing the osteal disease in any given segment. Number two, when you are doing imaging, please do the proximal optimization, then put the imaging catheters. God forbid that while taking these catheters with part of the stent hanging outside, your guide comes and hits the stent or your wire comes out, you will be spending minimum 1.5 to 2 hours. Maybe you might require additional 1 or 2 stents, because you would have crushed, gone substrate and done a lot of things because your first IVUS run post plasty showed a very grossly under expanded stent in the left main segment. So that I'm most scared of.
Okay, sir.
Correct. Number three, in your IVUS interpretation, you talked about a lot of calcium, but this vessel didn't have so much of calcium as you were describing it. So whenever you have calcium in a coronary segment, you'll have complete acoustic dropout. You'll not be able to see anything beyond that plate. So there were very, very few frames which showed us that.
Yes.
Correct. There is always different ways of approaching a given lesion. And if you take the absolute cutoffs for the choice of selection of a provisional versus a two-stent strategy, there are different cutoffs. So I will not go into that. I respect your decision to have gone in with 2 stents and done the case well. But these points you must keep in mind. They are important ones. The imaging to be done after optimization, the ostia of the vessels. In the final post run, you definitely showed us the catheter floating into the aorta. So those are runs. Those are simple things you must do when you're doing a pullback from the circumflex. You must ease the tension in the guide. Otherwise, the catheter tends to jump out, and if it jumps out, it will not be able to assess the ostium very well. Correct? But having said that, I congratulate you. Nicely uh, done case. But these are few tips which, if you take along with you, will help you in your future endeavors. All right. Any other comments from the co-panelists or the experts?
Police here.
We are eager to listen to sir.
Listen to?
Sir, listen to you.
Okay. Okay. I'm just looking. I hope I don't share a wrong presentation.
Just a small point regarding the crushing technique. You mentioned that you've crushed with a 3 mm balloon. It's always good to crush with a much bigger balloon, at least a 3.5 in the proximal LED, so that you crush it properly. And you saw that it was a left main, which is 5 mm left main. Probably go at least with a 4.5 mm balloon for a second crush without extending your balloon into the left hand descending artery, so that ultimately you wouldn't have a wire going into the circumflex artery through the two layers of the partially crushed stent over there.
Right, sir.
All right. My slides are seen?
Yes, sir.
All right. I don't know from where this yellow bracket has come. I didn't put it. Okay, fine. So this is one of the old slides, and it's one of my favorite slides. This is a statement from ACC which says that all cath labs should have imaging capabilities, and intravascular imaging is important for complex diseases, and we need to educate each other so that we reach a point where we can use imaging. And if one has to select between the two technologies, which means if one has to select between IVUS and OCT, IVUS is much more flexible option, and it can be utilized in almost all clinical scenarios. Now, if you see here, defining plaque morphology, both the modalities appear to be equal, whereas if you see the advantages, the IVUS scores over OCT in osteal diseases in left mains, particularly when you have to define the ostium or you have to look at the plaque burden. Chronic total occlusions, IVUS is phenomenal because it not only guides your wire, it tells you the exact sizes. You can't inject into the vessel because you've kind of done ADRs and you'll produce more dissections. And yes, we know that in renal insufficiency patients, it's phenomenal. So these are certain virtues of having IVUS on board. Are you all seeing a yellow bracket, or I'm seeing it on my screen?
No, sir, it's not visible to us.
Wonderful. Then it's good. So we have a new system called Makato, which is been in the country, and it's a dual pro imaging system. That means you get the dual insights. You have an HD IVUS, which tells you about the structure, and the NIRS, which tells you about the plaque composition, and images are co-registered. Co-registration implies that wherever you're seeing a plaque, you'll also get to know the composition of that plaque. Now, the Makato system is slightly different because it has the higher pullback speeds. It goes up to 2 millimeters. The camera moves in a bidirectional fashion. That means a click of the button, automatically it comes back to its original position. It's got a wider range. It's a very sturdy catheter with good pushability. And most importantly, it produces unmatched imaging quality. It provides you very good images. Now, it also characterizes the lipid plaque. It's got a very high sensitivity, specificity of picking up lipids, and it does this in a color-coded manner and what is described as chemogram. And this was validated with 2,500 cross sections of the coronaries, and in 2008 the catheter got the US FDA approval for detecting the lipid core. So with the sensitivity specificity of nearly 95%. So it not only detects, it also quantitates. We've been discussing this, and it quantitates by what is called the lipid core burden index, which is scored from 0 to 1,000. And the catheter is going to mark an area. As you can see here, a yellow bracket. It marks this area close to 30. You see the top yellow bracket. It marks the area which has the maximum lipid core burden index as max LCBI. Now, anything more than 400 max LCBI is associated with four-fold increase of MACE. So if the LCBI score is 824, it means that 82.4% of this necrotic core is lipidic. That means that such high content of lipid pool in the necrotic core is noticed. So as I mentioned, in 2008, it got the FDA approval. In 2010, the IVUS NIRS got the FDA approval. 11, it got the CE mark from the European Society of Cardiology, and PMD approval in 2014. Now, why did I put this slide? This slide I put here just to tell you all that this is not an investigational tool. This tool has been around for some time, and most importantly, it has been approved by all the major cardiology societies of the world. Now, how has this changed my practice? Let's look at the acute coronary syndrome. We know that we image and we need to know about future coronary events. It is a unsaid fact that in STEMI, plaque instability is not there, not only the infarct segment and the infarct related artery segment. It's also there in the non-culprit segment. And the MACE at a later date is probably because of the non-culprit vessels. So one needs to know the composition of plaques in the non-culprit vessels so as to prevent the future events. Now, neither IVUS nor OCT can characterize the composition of the plaque in the NCLs. Now, we have been using OCT and to detect the vulnerable plaques, and we always say that, one second. We always say that the vulnerable plaques lead to future events. But if you look at major registries of the world, the vulnerable plaque on OCT, going by the definition of the thin cap fibrous capsule being there and its thickness being less than 65 micron, is just about 4.5 to 5%. So IVUS provides us certain surrogate markers, and IVUS NIRS also adds to those surrogate markers. Now, what are these surrogate markers? The first one is the presence of positive remodeling. As you can see on the screen, the mere presence, as the green color denotes the cap thickness of less than 65 micron, whereas red is cap thickness of more than 65 micron. So if you see mere presence of remodeling increases the chances of plaque vulnerability. The same is the case with the plaque burden. As you can see on the x-axis, as the plaque burden increases, the vulnerability of plaque increases further. So with the plaque burden of less than 65%, only 6% of plaques are vulnerable, whereas if you have a plaque burden of 85% or more, 40% of these plaques become vulnerable. Now, same is with the lipid arc. As the lipid arc increases to around 350 or so, you see the green squares, the number of green square increases. That means these are the plaques with a larger lipid arc. These are the ones which will have the cap thickness of less than 65 micron. And the same holds true for the LCBI scores. Most of the LCBI scores are seen when the cap thickness is less. So what IVUS NIRS does is that it gives you a very comprehensive assessment of your lipid-laden plaques, because it can pick up all these four qualities. It can show you remodeling, it can show you the plaque burden, it can show you lipid arcs, and it can also quantitate. So it's a very comprehensive tool for picking up vulnerable plaques. As can be seen on this slide, if you add LCBI of grade more than 35%, it increases the sensitivity of picking up vulnerable plaques by 17%. And if you add the positive remodeling, it increases it further by 6.5%. Now, this has been proven. And if you see this slide, the maximum event rate was in patients who had plaque burden of more than 70%, the top blue line, and those with more than 324 LCBI score. So if you have plaque burden as well as high LCBI score, you're likely to have more events. Now, the natural history of the vulnerable plaque, we need to detect progression or regression. The progression is best detected on OCT, and progression is characterized by presence of PICFAs, neovascularization, and healed plaques. Whereas regression is best picked up by IVUS NIRS, and regression follows this undermentioned sequence. The first thing to happen is thickening of the fibrous cap, easily picked up on IVUS NIRS. The next is reduction in the lipid pool, which you can pick up by decrease in the LCBI scores. And the last to happen is reduction in the plaque atheroma volume. So these tools complement each other. But if one has to rely on tools, if you put patients on medication and you need to check whether things are going in a manner in which they are supposed to be, then IVUS NIRS is very valuable. It will definitely show you signs of regression, and there are studies which have proven the same. Now, PREVENT trial made a lot of noise, where they basically looked at two of the four things. That means the MLA, LCBI score, presence of thin cap fibroatheroma, and plaque burden, and they went ahead and did some stenting. So what this trial showed was that there were certain markers which could predict the events at a future date. They looked at plaque burden, which had a hazard ratio of 1.92, as you can see this. But the major predictor of events in the PREVENT was the LCBI score on follow-up, with the hazard ratio of 3.38. Now, LCBI was one of the most important predictor of future event rates. Decrease in the MLA was not associated with increase in event rate. So if you have smaller MLAs, and this target vessel failure was studied at the end of 5.4 years of follow-up, and they found that MLA was not a very great predictor of events vis-a-vis the other two important factors, which is plaque burden as well as the max LCBI. And max LCBI stood out to be one of the most important predictor of the target vessel failure. So the virtues of NIRS in ACS is that it does not require any blood clearing. You can assess the lipid pool in the vessel regardless of the stent strut's calcification or its location. There is definitely a grading in the LCBI score which increases progressively from non-culprit vessels to patients of STEMI who have the highest score. So it not only localizes the culprit lesion, it also stratifies your non-culprit vessel, and it also tells you that these are the plaques which will respond to the lipid lowering drugs, so that you can take the prescription out of the cath lab and treat these patients. I'll show you a couple of case examples. This was a case which I did in Nagpur. Some haziness in the proximal LAD, everything else looked okay. So this was a patient who had, this is the pullback from the LAD. Now what stands out is clear images, and these are IVUS images which are very easily interpretable. You can see dark band of media, and now you see in the lumen there is haziness. This is thrombus. This is thrombus, and if you do OCT in such situations, you will not see anything beyond the thrombus. And this is the still image. The dark band which you see is the media. There is a minor plaque here, and the commensurate chemogram showing LCBI score of 338, and that's the thrombus there. So this is a classical example, and if you see the plaque burden is very minimal. So this is a classical example of a plaque erosion where a minor injury to the intimal surface led to thrombus formation in a young patient. Now, IVUS also guides us in assessment of the non-culprit vessel, and this is one such case, and it's a very important thing. The LAD was blocked, LAD was stented, no major deal there. And this was the pullback from the circumflex of the non-culprit vessel. You see a calcific plaque. There's complete acoustic dropout which is happening, and you can see a lipid pool behind that. The LCBI score of this non-culprit vessel was around 654. And we went ahead and stented this vessel because it was proven in the LRP, which looked at about 1,500 subjects with the non-culprit segments, and they found that if you have an LCBI score of more than 400, there are 89% higher risk of these patients having an event, and these segments with these vulnerable plaques had fourfold higher risk of causing events. What this trial concluded that it's pretty safe to use this tool, and it kind of evaluates the non-culprit vessel wells. And this is the trial which got the device the FDA approval by stating that if you see a vessel segment of more than 400 LCBI score, this can lead to MACE at a later date. Now, Prospect and LRP studies both in conjunction prove that the high lipid content of the plaque is one of the major predictors of MACE, and it should be respected and treated accordingly. Now, you also use NIRS for guiding your prescription. As I mentioned, this was one case. I'll just run through it. With very high LCBI scores, this was a primary, but there was no thrombus in the lumen, but there was tons of calcium. You can see some reverberations, but the LCBI score here was 1,000. So nurse told us that this is a very high lipid rich coronary segment. Even in the longitudinal view below the chemogram, you can see there is complete acoustic dropout. There is nothing which is seen in the longitudinal section. We went ahead, we stented this vessel. There was considerable slow flow, as Dr. Balaji showed a couple of case examples. This is not unusual. And this was the final nurse. We didn't use any special atherectomy tools. It was just dilated with NC, and you see a nice circular expansion. There was still some residual score of NIRS of 475. Now, it has been proven in the yellow study as well as in Pacman AMI that if you use statins or the PCSK9 inhibitors, you'll be able to bring down this NERS score considerably. And this is protective. And this happens over weeks, if not over months. And so plaque modification is possible. And this kind of gives you an objective parameter to be followed up in OPD. And this kind of also ensures the compliance of medication in the OPD with the patient, because most of the patients kind of stop high dose statins, and most of the cardiologists also stop high dose statin after a fixed period of time without really knowing what is happening inside. Now, calcific lesions, we need to stratify. No, macroscopic calcium is not a predictor of a major event, as was shown in the prospect trial. But we know that mere presence of calcium is not an indicator of high lipid content. There is a discordance between the plaque burden, coronary calcium, and the lipid pool. So we need a tool which can tell us that, okay, this calcific lesion has got lipid pool. Lipid pool implies that this is a plaque in evolution. This is a plaque which is dynamic. This is a plaque which, when if it ruptures, can cause thrombosis, vis-a-vis a plaque, calcific plaque, which doesn't have any lipid pool. The plaque without the lipid pool is biologically inert and will not cause any major events in this patient or the ACS. So NIRS is capable of peeping through the calcium plate, which neither IVUS or OCT can. And this property of NIRS has been used in the past for checking the cerebral oxygen content. And now it basically characterizes the plaque composition, but it does not temporally localize. As you can see, this nodule has got lipid within, and this is a nodule which is sitting over the lipid pool. Now, in both these situations, NIRS cannot tell you whether the lipid is within the calcium or behind the calcium. It just tells you that there is lipid behind this calcium plate. Now, this was one such case, a nodule in the Prox LAD. As you can see, this was the nodule. We were ready with our atherectomy tools till the time we did IVUS NIRS, and we noticed that a circumferential calcium here had a very high LCBI score of 816. As you can see, right at the point, the bracket which tells you about the LCBI is against the segment where there is complete acoustic dropout. What we did was balloon dilatation, and this is one of the rare cases where in a native coronary artery, I used a balloon to dilate a nodule, and we had slow flow in the given vessel. You can see there is a considerable slow flow which happened, and we were kind of confused as to why this has led to it. At that stage, this was very early in our usage of NIRS. But do all calcific plaques have lipid? No, the answer is no. This study looked at 20 asymptomatic patients, and it noticed that almost 40% of these individuals did not have lipid-rich plaque. There is a positive correlation of plaque burden with calcium score, but calcium score does not correlate with the lipid pool. As you can see in this graph, there is absolutely no correlation between the calcium score and the lipid distribution. One such case of anomalous RCA, where we went ahead, stented the proximal segment first, and then we did the rotablation of the distal RCA, which had a lot of nodules. And if you can see this vessel didn't have a very high LCBI score. There was complete spectrum of calcium. I'll show you here. The LCBI score was just about 204, but you could see calcific nodules. You could see circumferential plate with a little bit of lipid. You could see thick plate with multiple reverberation, thin plate with single reverberation, fractured calcium. So everything was seen. This vessel was stented. And as is seen, there is some amount of malapposition, stent deformity, under expansion. Everything was seen, which was later optimized. And this was the final result in this RCA. Now, this case is routine provisional LM-LAD stenting, but I like to show this case in most of my talks. The reason for showing this is the quality of the NIRS images. This is a pullback from the LAD. As you can see, I haven't seen better images. A large left main, which is, LAD, which is merging into the left main. Now you see a circumferential plaque. That's the circ which is joining. You can see each and every structure so very well defined. Now you have a circumferential rim here with complete lipid pool. This is the proximal left main with plaque burden. And similarly, you can see the pullback from the circumflex. I hope it plays. Yes. So pullback from the circumflex. As I was mentioning, if you're doing left main, you need to have pullback from both the vessels. And you see again a complete circumferential rim. The proximal part of the left main was essentially normal. There was a little bit of plaque burden, which is seen here. I've edited the images. So what we did here was just the provisional stenting, but you can see here there was a deep nodule also present. So we had to kind of do high pressure dilatation, but we got very good results of the provisional stenting. As you can see here, we didn't do anything to the circumflex and we had very good results. So the algorithm which we follow is we check if the calcific lesion is balloon crossable or not. If it is, we do imaging with NIRS. If it is not, then laser or rotational atherectomy is the way forward. Then you look for the LCBI scores. If the LCBI scores are very high, plain dilatation with NC balloon and optimal stent expansion. If the LCBI score is on the lower side, then you definitely need some atherectomy tools depending on your familiarity and the resourcefulness of patient. You can select any of these tools and optimally expand the stent. So LCBI can help you downgrade the tools to a very great extent. Where you're thinking of using orbital or road ablation, you can go down to NC balloons and do it. Now, I included these slides, but there was a question whether the residual score predicts. So this is the 202 patient data where they left LCBI score of more than 200, and they noticed that this was a predictor of target vessel failure, and they concluded that each 100 unit increase of NIRS max LCBI in the stented segment led to 1.6 folds increase in the target vessel failure. So retained lipid contents as detected by NIRS can be a predictor. So at least this can be a surrogate marker for you to use statins for a little longer period of time. Now, neoatherosclerosis, we get to see a lot because you're using medicated statins. So NIRS has very high sensitivity of picking up lipid core plaques, which neither of IVUS or OCT can. And this does not distinguish kind of neoatherosclerosis from fibroatheroma behind the stent. As I mentioned, that it does not temporally localize. And it has also not been associated with peri-procedural MIs in whatever little follow-up which has happened. To summarize, I would say that this system is slightly different. It's the first dual imaging modality in our country. It's got a bigger imaging range, higher pullback speed, bidirectionally moving catheter, and a sturdy catheter with good pushabilities. It has certain virtues over IVUS and OCT because it gives you the plaque composition, which kind of helps you predict MACE. In the characterization of the plaque, even behind the calcific plate, helps in optimal plaque modification, and it takes the prescription out of the Cath lab to the OPD where you can prevent stent failure rates when using it. Now, this is a good imaging system which is kind of approved by most of the societies of the world. It not only predicts tells you about the plaque composition, but helps you predict MACE rates at a future date. It stratifies the calcific lesion and optimizes your plaque modification tool selection. It tells you that in a given patient how long and how much of lipid lowering therapy has to be used. So it's a very, very comprehensive tool. But if I have to mention one very important point about this tool, which is that the image quality. IVUS is one modality where most of us have started. When we started, we said that, okay, I really don't know what am I looking at. But that doesn't happen with NIRS. It gives you very crisp and good images which are easily interpretable. But we need to work further. We need some more trials in this segment, and this will help us widen its applicability and usage in clinical practice. Thank you for your patient hearing.
Sir, as usual, beautiful lecture, very informative. Sir, I think with the usage of IVUS NIRS, now what percentage do you use OCT in your cath lab? What would be your regular IVUS and what percentage do you use NIRS IVUS?
So that's a good question. I preserve OCT when I need to look at the close-up images. So in stent failures, I prefer OCT. In bifurcation stenting, since I get a lot of 3D information, I mean PPCT and cranial tip angles and wire recross and 3D reconstruction of the stent or the wire recrossing. So in those situations, I prefer OCT. But more or less, what is happening, Deepak, is that we have 4 labs working together. If IVUS nurse is engaged in the other lab, then I pick up OCT. But I have been in OCT for more than a decade, so very difficult to do away with OCT. But it definitely has. What I would like to say is that imaging is got future, and one must use imaging in complex cases. I'm not saying that use it in all the cases, but in complex lesion subsets, especially left mains, bifurcations, calcific disease, and small vessels where sizing errors can be important in defining ambiguous lesions. So, and we do a lot of post-primary stent optimization. It's mandatory in our lab that post-primary, all patients will undergo imaging before they are discharged, and we do a lot of corrections in the implanted stents, and I've been a very strong advocate of that.
I would like to request our expert panelists if you have any last comments or want to discuss something.
I think I had a very beautiful discussion with sir when he was here in Mumbai. So a lot of queries were solved when I started. I did my first Makoto IVUS with sir only, and after that I've done about 6 more. So it's been very interesting.
I remember that triple vessel disease case of yours, Rahul. That was
Yes.
really well done.
All DCBs, I think 5 DCBs we used. Patient was for the
Surgery.
transplant. Is for the
Transplant, yeah.
Dr. Viveka, sir, would you like to ask something? Dr. Balaji.
So I mean, if one motivates oneself to get into the realm of doing IVUS, I think this is one of the most amazing systems to have. And by virtue of good imaging quality and additional information about the plaque characteristics. So I have been a very strong advocate only on those grounds. But I mean, if you feel that you have access to OCT, do imaging. What I say is that do imaging. And yes, if you have to pick and choose, I gave in my first slide the virtues of IVUS. And if you're kind of discouraged about inability to interpret the image qualities by virtue of IVUS, then I think Makoto system is the system for you. It kind of overcomes that limitation of IVUS and gives you very sharp images which are easily interpretable. That's what I would say in my last comment for this evening. I think we've had a fantastic webinar. So
Thank you so much, sir. Thanks
any
a
other
lot for
comments
your
from
guidance.
anyone? Most welcome. Thank you. Thank you, Gauri.
Any last comments from Piran Kapardi, sir?
Thank you, ma'am. I joined in between, and I have bulk experience. IVUS NIRS. Definitely, it has impacted the resolution if compared to other IVUS machines. The resolution is almost equivalent to that of OCT. And I think after all primary angioplasties, a culprit vessel along with a non-culprit vessel we have to do, so that uh, aggressive lipid lowering therapy is you can choose, and you can predict the events. Dr. Chadda's beautiful that lecture we came to know, and most important is underutilized. That is the main drawback. So we should know the proper utility of this IVUS NIRS, especially not only as an interventional tool, but it's a bridging tool between a preventive cardiology and interventional cardiology. As nowadays, sometimes aggressive lipid lowering therapy is needed along with statins plus PCSK inhibitors, whether we have to use depending upon the LCBA scores. I think they are the future unmet needs, so that we can gain the additional information to prevent our recurrent events in future with all the patients with high LCBA indices.
Thanks a lot, sir.
Right.
I would like to request Dr. Deepak sir also for any last conclusive words.
That's it. That's it. As spoken by everyone, the beautiful image quality, that's what attracts everyone towards this particular IVUS NIRS system. And in addition to that, you have yet another modality of imaging, which gives us more of information while managing our patients. And that's it. Thank you so much for arranging such a good meeting. Thank you once again. Thank you all.
Thank you so much, sir.
Thank you.
So on the behalf of Veiva Scientific, I extend our heartfelt thanks to each and everyone who has joined us today for this insightful session. And a very special thanks to Dr. D.S. Chadda sir and Dr. Deepak sir for guiding us through the entire session and giving us their valuable time. I also would like to thank our expert panelists and the speakers for sharing their expertise and knowledge. Thanks a lot to all the attendees as well. Until we meet again the next time. Thanks a lot. Good night and take care.
Thank you. Good night. Thank you.